Hello. Thank you again for joining us today for Fireside Chat with Encompass Health CEO Mark Tarr and Outset Medical CEO Leslie Trigg, as they discuss how Encompass is shifting the paradigm for dialysis in the rehab setting. Leslie, over to you.
Thanks so much. And a special thanks, of course, to Mark for joining us here today, and to everybody listening in. We have a pretty big crowd here. So thanks for all the interest. Mark, I'd love to maybe start by talking a little bit about Encompass at a high level for those joining us today that might be less familiar with it. It is one of the nation's leading post-acute providers, fast-growing, widely admired, visionary company, publicly traded on the NYSE. What else can you tell us about the company's profile in terms of size, footprint, focus areas, and so forth?
Well, thanks, Leslie. First of all, it's a pleasure to be here and participating in this today. So yeah, we are very proud in Encompass Health to be the largest owner-operator of inpatient rehabilitation facilities. So as of last week, we opened up our most recent hospital. A shout out to our team in Bowie, Maryland, for being number 158 in our organization. Those 158 hospitals are spread across 37 states, plus we have 2 hospitals in Puerto Rico. From a market share standpoint, we make up 25% of the total licensed beds of all inpatient rehabilitative facilities cumulatively. And we account for 1 out of every 3 Medicare patients that will be treated at an inpatient rehabilitation facility this year will be treated in an Encompass Health hospital. So we're very proud of both those. And we're really most proud of our 36,000 staff members that care for these patients or are helping support the care for these patients. So we wouldn't be anywhere without our staff.
That's a remarkable statistic right there, and speaks to, I think, speaks a lot to Encompass's rapid growth. So I'd love to learn a little bit more about that. What the most important strategic growth vectors that you're focused on, and maybe you talked about your newest market in Bowie. As you're entering all these new markets, what strategic approach does Encompass tend to take from a structure standpoint vis-a-vis JVs or partnerships or wholly owned entities? I'm curious about that.
Yeah, so we have been busy in the last 2.5 years. We've opened up 20 brand new inpatient rehabilitation hospitals. So we have growth targets that we have set for our organization. We have 6 to 10 new de novo hospitals each year. And then we are focused on adding to our existing set of hospitals that have reached a capacity or occupancy where we need to add beds to enable additional growth and to care for those patients that are referred to our facility. So we're looking at adding between 80 and 120 new beds to those hospitals. And then from a discharge standpoint, 6 to 8% discharge CAGR per year. So those are the metrics that we're most focused on and have shared with the investment community. So part of our strategy of growth, and this goes back to our first joint venture partnered hospital with Vanderbilt University Medical Center in Nashville over 30 years ago now. So about a third of our portfolio, actually we're now up to 62 of our 158 hospitals are partnered with acute care hospital systems. And that's been a nice strategic focus for us. That is either through our approaching the acute care hospital systems that maybe have a smaller IRF unit that they would like to expand upon, or they've reached out to us when they are searching for a strategic partner, someone that really knows how to manage this particular niche within post-acute, and can also be a capital partner for them and going out and separating maybe a unit that is housed within their acute care hospital system somewhere to a freestanding hospital from which they can grow and also be a big part of that post-acute setting for them. So yeah, we're growing and either wholly owned or partnered hospitals. We're very excited about the growth we're experiencing.
Well, growth never comes easy. There's always, headwinds pushing in the other direction, and it sounds like there are quite a few tailwinds. But if we think about the space in general, this post-acute, subacute space, what do you spend a lot of time thinking about for the subacute or the post-acute industry, headwinds, tailwinds, and things in between?
Sure. So last 4 quarters, trailing 4 quarters, we've treated over 216,000 discharges.
Wow.
And so I'll start with the tailwind is really the aging demographic. As we all age, the likelihood for us having either a condition or a circumstance that would lead towards the need for inpatient rehabilitative care increases with age. So our average age patient is right at 76, 77. So if you think about the aging baby boom generation reaching that age cohort, that is producing for the last couple of years now, it's been a 5+% CAGR of that age group into the Medicare beneficiaries. So that has been a bulbous of additional patients and increasing demand for our services. So that's what we think about in terms of, what can we be doing to position ourselves ahead of that growth and be ready to serve those patients that are needed. Relative to headwinds, I think that we would be no different than any other healthcare provider out there, hospital provider out there, is that labor is a challenge. And whether that is just the inflation inflationary cost of labor itself, or just the scarcity of labor, but that is something that certainly has spiked for the past couple of years. We're starting to see some normalization to some of those patterns this year, but that is something that we think about and deal with every day.
And as you think about your customers, your health system customers, what are some of the biggest challenges that you're committed to solving for them, or the value that you're trying to create for them?
I think first and foremost, we want to provide great patient care. We want them to feel comfortable that they are referring patients and patient families to a setting and a particular provider, that they are feel comfortable with the patient care. So that's first and foremost. And then, secondly, we look at our referral sources as our customers. We want to make sure that we are being responsive, that we are a post-acute provider, and specifically an IRF provider that they can count on, that they know is consistent in terms of the messaging, and someone that is being responsible to their needs. They're under a lot of pressures in the acute care now to work patients through the system, and the sooner we can get them answers relative to the suitability of their referred patients, our ability to care for those patients, do we have available bed, all that goes into the from the way we view it in terms of wanting to be a good provider and being a good, whether that is through a formal or informal process, being a good partner.
Yeah. Well, I think some of the challenges and the opportunity and value that you touched on maybe plays into dialysis care a little bit. And I know a little bit about this story, obviously, but for everybody else, maybe describe the dialysis care model, sort of the before and after picture, and maybe starting with the before picture. How was Encompass managing and serving dialysis patients in your facilities, and what did you ultimately come to view as sort of the limitations or the drawbacks of that model?
Sure. So I mentioned earlier that we treated the last trailing 4 quarters, 216,000 discharges, and just to put things in perspective, about 5.5% of those discharges are patients receiving dialysis care. So that gives you a bit of a picture. We've always felt that in those marketplaces where we had the capability of serving dialysis patients, we should be doing, because there are patients that are terrific rehab patients and should not be denied that rehabilitative care just because they happen to be needing dialysis. And so historically, we have either contracted that to be provided in our hospitals by an outside provider, or and it's been several years ago now, that there were times when we would have to transport our patients to an outside location to receive that dialysis care. So neither one of those were ideal. And then with the past several years, with the nursing shortage and resource shortage, we had a number of the providers of dialysis for us come and tell us that they were no longer were interested in treating our patients. And we were committed to those patients and those types of patients. And so we started searching for alternatives, and up to and including the opportunity for bringing that service in-house. And Tablo has turned out to be a fantastic alternative for us, and has really filled the need in terms of a solution for us in many of our marketplaces.
Well, I'm sure as your team was going through the process of contemplating the right model, is insourcing using your own team and Tablo, is it really the right solution at the right time? I can only imagine there were a number of concerns, question marks, considerations that, were on people's minds. I'm curious what sort of rose to the top of the question list, any concerns and worries. And then I guess on the flip side, sounds like the story has a happy ending, but were any of those original concerns and questions realized? What did you learn along the way?
It's like any new program, any new clinical program that we would be establishing in our hospitals. Our teams want to make sure that that they have the expertise to do that we have the proper amount of equipment, staffing, space in the hospital, that we provided the proper amount of education to get people comfortable with that. So those were all things that we went through before we were able to establish this. As you know, our one of our 3 hospitals we have in the Las Vegas marketplace was really the standout in this, and became kind of our test site location and prototype from which the genesis of this entire program started. So we very much appreciated the leadership that team showed there, starting with our CEO there and working with all the clinicians. And we have a number of employees from a national standpoint, our chief nursing officer for our company, our chief medical officer for our company, all helped us to evaluate what we needed to have in place to safely start bringing this service in-house, working closely, Leslie, with you and your team to make sure that we were ready to do what we needed to do on behalf of our patients. And it really has, it's turned out to be something that has been, it's a win-win for our patients, and that's what's most important. And from a scheduling standpoint, from a care standpoint, it has, really enhanced the entire experience for our patients. And it is a much more patient-centric way to approach it than what we had experienced before when we were dependent upon an outside service to come in. We were very dependent upon their time frames. It wasn't our patient scheduling, it was their scheduling. There was inconsistent staffing. And so on any given day, it was unsure in terms of what we'd be facing in our hospital when you kind of have the lack of reliability. And so all that has been solved, yes, through working together with the team from Tablo and what our team have done internally.
And what does it look like today in terms of the rollout? What's the current state?
So we're at 62 and counting. So we have 62 hospitals that now have the Tablo equipment in there. We think that it will be up to 90 by the time we finish this year. And then we've got a nice rollout scheduled for well, quite frankly, throughout 2024. I think we have another 30 identified for 2024. So, it's been an aggressive campaign to roll this out. Our organization's pretty good at taking best practices and then rolling them out. We've shown that time and again, and I think that is helping to benefit us as we roll out the Tableau service.
Yeah, I get that question a lot, and I'll give you some feedback here too. I mean, I do get this question a lot about how do some of your organization and others, how have they rolled out insourcing as fast as they have? Just from a change management perspective, it's really impressive. I think what we do see some common denominators between organizations, and Encompass in particular. I would say number one, consistently planned for success ahead of time by creating and implementing routine practices, starting with kind of a program implementation playbook that every site was going to follow. I think the second thing we see over and over again is just very high effective open communication between our teams and then amongst and within your own teams. Also talking about things that aren't going well, because I think with change of this magnitude, as you well know, you're going to learn a lot, and there's going to be problems along the way and things that aren't anticipated. And so we see the greatest success with teams, again, both our side and your side, about escalations and concerns from kind of a solution-oriented mindset. And I think Encompass, the leadership team and the employees have been phenomenal examples of that. I would also say that feeds into a lot of trust and rapport and relationship development. I think both of us having the desire to perform with excellence and create success, for the other is another, I would say, common theme. And lastly, one thing I've heard from my team a lot about Encompass is that all of our interactions are what we would call transformational, not transactional. It's not just about checking boxes and sort of getting something done. It really is consultative and peer-to-peer, addressing questions and making sure that we have the right expertise at the right time. So I'll tell you from our vantage point, Encompass is the best practice example of all of the providers that we've worked with to date. So I want to compliment you on that, and just share again for others listening what success looks like, because it doesn't happen by accident.
Well, thank you for that, and yeah, we that's part of what makes our team so great. And we try to share a lot of information across our entire company. We have numerous management reports that identify best practices. So it doesn't matter whether you may be in Las Vegas, but the people in Las Vegas can share information with the people in Mechanicsburg, Pennsylvania, or Dallas, Texas, or you name it. So that's part of just kind of that sharing information. And as you noted, it's not, you don't want to just share the good information. You want to share the challenges too, so that that the next maybe the next hospital doesn't have to go through some of the same challenges that you may have experienced the previous rollout, and you kind of learn from all those that went before you. So I don't know, maybe the secret is not sign up first for it, but be number 5 instead of number 1.
Yeah, exactly. Fast follower. So did your team have? I'd imagine they have, because this is a hallmark of good execution. But I'm assuming they established probably some KPIs and metrics, or at least objectives. Here's what matters most. Here's what we're really looking for, maybe in program 1, 2, 3, 4, 5. What were some of the ways in which you measured success of the program, early on, or how you measure it today inside?
Well, I mentioned earlier some of the things that made it challenging to have, and I'll define it as being lack of a high performing third party provider. Let's just say that. And so we would often have patient schedules that were interrupted, or we're required to have a minimum of 3 hours a day of therapy for our patients. Can make it very challenging to have dialysis that is not provided at the same time, where it's conducive to appropriate scheduling for the patient. So that was a key focus for ours, and wanting to make sure that the patient schedule was appropriate for them to get the necessary therapy that they needed. I would say, another thing was just a good experience for our patient as part of the patient experience focus and the quality that we're trying to provide our patients, not only for the outcomes or the number of hours of day of therapy. It was it provided in a manner that was met their expectations and an overall good experience. And then I think that another very important thing that's really started to show in some of our initial trends too is are we experiencing fewer acute care transfers for our dialysis patients, and is the dialysis care more of a kinder, gentler approach for our patients where they can tolerate it and still tolerate the therapy and not have steps backwards that would necessitate them being readmitted to acute care, which is what we're seeing. We're starting to see few of our dialysis patients being readmitted to the acute care hospitals, particularly in those hospitals where we have the Tablo device. So those are all some metrics that we look for and wanting to make sure we're providing the necessary care for dialysis patients and doing it in a manner that really is reaching an optimal level of care.
So you've actually seen a reduction in readmissions?
We're early on, but yes, that is a metric that is starting to show itself, and something that maybe even within a year from now or so we can look back and do a year-over-year comparison and really start to show some data that is around that. But this is a marker that's starting to show itself for us.
Yeah,
which is very exciting.
Yeah. Have you heard anything from patients, or have your team heard anything from patients themselves? You mentioned about kinder, gentler, which I think you are borrowing from George Bush, if I recall. I guess we're both old enough to remember that those days. But have you heard any feedback about how patients are feeling physiologically, psychologically, otherwise?
It's definitely our patients are coming through dialysis at a higher level than maybe they have historically done, and and I use that term kinder, gentler. That's exactly what it is. It's getting the process itself is not having near the side effects or the degree of the side effects that otherwise would have been expected with taking a patient that maybe, well, as I noted, 76 and 77 is our average age patient. So you could be taking a patient in their high 70s or even in their 80s, and it can wear them out. And but the process seems to be really working better for our patients, and they're not as exhausted as we would have historically seen. And so that's part of that whole patient satisfaction, better experience. It's just overall, like I said, our approach to this is that it's a win-win for the patient, and then it's a win-win for everybody, and that is just part of the story for this.
And I would imagine, but you tell me, that if people are feeling less fatigued and feeling well, are you able to deliver more rehab therapy to patients as a result of that?
Absolutely. So it makes it a potential to have the treatment in the morning and the therapy in the afternoon, or whether you want to look at it that way, or if nothing else, they are less exhausted at the end of the day, so they're even better prepared to begin the next day. Mm-hmm. So it's that part has been obvious to us and our clinicians, most importantly our clinicians, that the treatment itself is not as taxing as what historically has been.
Yeah. We did get a question in here from the participant ahead of time that was talking about whether you've been able to shift the time patients receive dialysis. This is a similar question, but a little different. Has this given your facilities more flexibility around when they could be treated to be ready for their intense rehab?
No doubt. I mean, the fact that we know we can schedule things now to a degree of certainty that we couldn't before. If we were at the beck and, kind of the beck and call of the schedule of the dialysis provider, that's a lot different scenario than establishing the time frame for the patient to receive their dialysis treatment that is compatible with their therapy schedule. So it definitely has provided a better means for planning for our staff, both nursing and therapy staff, as well as the patient themselves. And then it just having that certainty on a daily schedule means a lot for our patients, and it means a lot for our staff as well.
Yeah, that's great. I've got another question here in the Q&A, and just as a reminder to everybody listening, please feel free to write Q&A in the chat or in this Q&A box. But here's another one. I think it's a good one to ask and answer. Of the 62 hospitals that you mentioned, this person's question is, on average, how many tableaus are in each facility? Part one. Part two, are the machines used at the bedside, or do you also have like a dialysis room? So a little bit more of an operational question here.
Yeah. So our prototype model is to have 4 chairs in a suite. So we 4 chairs and 4 Tablo devices. So we have been in the process of modifying, going in and doing the revisions to our hospitals, and reallocating space to create a dialysis suite in our existing hospitals. In our new hospitals that we've been building for the past couple of years now, we have accommodated that and designated that from the very start to have a dialysis suite. So, going in and backfilling the space and the plumbing and everything that's necessary for it is not it's not inexpensive.
Yeah.
But it's a sign of our commitment for this program, I think, and it's a better experience for the patient too. We definitely would prefer to do it, and staffing is a better situation too when you can have two nurses in a room caring for 4 patients total.
Okay.
And it's we make very it's a pretty good setting, not only for the patient but also where the care is being provided to. So we want to make sure that we're providing a setting that is attractive for our staff to want to work.
Yeah.
It's not some back room, some dark closet. We've made it. We've stepped it up.
I've got one more kind of operational question, and then we've got numerous questions coming in here on cost reduction that people are interested in. But here's the operational question. So do you schedule dialysis always in the morning and therapy in the afternoon? How do patients tolerate it? I think you've talked about that, but is it set, or does the schedule?
It varies by hospital to hospital,
Okay.
Depending upon the number of dialysis patients they have. And kind of their system. I think in an ideal world, you'd have a dialysis care in the morning and therapy in the afternoon. But that varies by hospital, and what best suits the patients and the hospital itself.
Yeah, sure. But at least you have the flexibility to,
You absolutely have the flexibility
around the patient versus somebody else's schedule. Well, multiple questions here on cost savings. You touched on being able to change your labor model as maybe as one element of cost savings, but folks curious if you could talk more about the cost savings that you're seeing.
Yeah, so the best cost metric I have is that historically, when we contracted out, or where we contract out, it's approximately on average about $600 per visit. And in-house now, we've kind of factored out the cost is about $300 per visit. So it's a pretty significant cost reduction. I mean, that clearly we have added some capital costs in there to build these suites out. But as we just look at it from the expense per visit, it's a pretty significant change.
Yeah, that is really, really cool. Couple of questions around who's providing the care. So can you talk a little bit about, somebody was curious whether you're using techs, PCTs, as you would find in a dialysis clinic. Somebody else was asking, are they dialysis nurses? Is it a mix of some dialysis nurses, some of your floor nurses that have become dialysis nurses? Could you talk about the staffing?
Yeah. So what we have are two nurses, two chairs, or two nurses, total 4 chairs, 2 patients per nurse. And so we've gone out and hired dialysis nurses. I don't want to say that there aren't any of our existing nurses maybe that have received the training, but certainly going into it, we have gone out and hired dialysis nurses to come in and set it up that way, which is working out. We've been able to hire. One of the things I asked about this week is, clearly nursing has been a challenge in hiring, kind of across the board for the past couple of years. So you asked earlier in terms of what maybe some of the hesitations, or not hesitations, but concerns going into it were from our staff. And one was just our ability to hire dialysis nurses. And would this be a situation where nurses would be interested in coming over to a rehab hospital and caring for our dialysis patients there? And we've had really good luck with doing that. I mentioned earlier about just a good setting to be able to work in and providing care for, and that's exactly what we've tried to establish as we built these suites out. So we've hired a number of new dialysis nurses to care for our patients in our new programs.
That's great. So net, you have found it, your team has found it maybe easier than they had feared to hire dialysis nurses.
Yeah, I would say so. I mean, I don't want to say that it's just. I think nursing is a challenge anywhere right now, so I don't want to say that there's not any challenges, but it's not been enough to slow our program down. It's not been enough to delay a program startup that at a point where we had hoped to get it started but can't get it started because we can't get it staffed.
Yeah. Another question here about a couple of questions around expansion and maybe your future forward vision. One question around, could you envision introducing kind of an insourced service into skilled nursing facilities? Do you think that, that would provide the same sort of patient, operational, and financial benefits?
Well, I could potentially. I mean, that's not something we're interested in getting involved with, but we've got, as I noted, we've got a pretty long potential development opportunities ahead of us as it stands just on the IRF side of our business, doing what we're trying to do here. But it could potentially be something that a skilled nursing facility would want to go out and see if it's something they want to do from a resource standpoint.
Yeah. Okay. And then a question here about sort of post-care. What is the continuity of care look like after discharge from Encompass? This is a subject near and dear to my heart around home. But there was and I promise I didn't make this up. This is not coming from me in the chat. The question was around, hey, is there an opportunity to send patients home as they've become familiarized with Tablo and with this form of dialysis in your facility?
I think so. I certainly a big focus of our teams are, just wanting to make sure we have a good transition at the time of discharge with whatever that next step is, whether that's, home with home health and making sure that there is a nice continuity of care at the time of discharge, or whatever that next setting is for a patient. But that is a priority for our teams at the time of discharge. And as we, who knows what, as we go forth and continue to evolve this and try to figure out how best to meet the patient needs that are out there, that there certainly could be evolutions to this going forward.
Yeah. This is a comment. I thought you'd enjoy hearing it from somebody in your Las Vegas team. You talked about the Las Vegas.
Shout out to the team in Vegas.
Yeah. So this person said, thank you for selecting us to help begin this journey. I agree the success of the rollout were the touch-based meetings almost weekly with Outset to go live The patients seem to have more energy to be able to handle the rehab the same day than experienced previously. I was honored to be part of the process, and Outset and the Encompass Health will continue to assist the community. So that's just a shout out back to you.
That's great. I mean, right there, that is testament of the type of individuals we have out there in our hospitals.
Yeah. This is actually a question that I meant to ask you earlier, and this person's reminding me of it. So how has the insourcing services now that you provide, has it helped your relationships with your customers? Has it had any impact on your referral patterns, sources, any benefits there?
Yeah. So I asked that question this week of one of our hospitals, people that are involved with it, and one of the things that they pointed out is the certainty that we have now, that we can say, yes, we have one open chair now for a patient to be discharged from the acute care hospital into our hospital, that we can accommodate that patient that needs dialysis care, versus before, if the whole scheduling was such problematic because we were counting on an outside firm to provide that and they weren't very consistent, then that put us in a bad position of telling a discharge planner or case manager in an acute care hospital, well, we may or may not be able to accommodate that patient today. We're not really sure if we can do it tomorrow. We'll have to see. That's not what the discharge planner in an acute care hospital wants to hear. They need to hear something consistent. They want to know that they can on the date and the time and the number of availability of beds, that for a post-acute provider, that is what creates that goodwill with the discharge planner or our customers here. And so, that has been another opportunity for us to enhance the whole referral relationship with that certainty, because now we can tell them, we have an open slot for that patient to receive dialysis care.
Yeah. And we certainly are hearing a lot about that from an increasing number of health system executives around an elongation of length of stay due to an increasing inability to find a chair in an outpatient dialysis clinic, largely because of staffing issues at the clinic level. So I'm not surprised to hear that. I think health systems are increasingly looking for alternatives to refer into.
Agreed.
So the hits keep coming here. One other question is, and this gets a little, operationally detailed, but I think this is kind of what people want to know, is a little bit more on the how-to. But this question is, are you providing dialysis every day, even on Sundays? That's not something that dialysis clinics offer. As you may know, they're 6 days a week. Do you offer this every day? And can you talk any more about your nurse staffing? Are the nurses working 8-hour shifts, 12, anything special, I guess, that you ended up innovating or doing differently in terms of the shifts?
Well, first of all, we're providing the care, whatever the care that our patients need in terms of the proximity and number of times. We'll be able to accommodate that. Relative to whether they're 8-hour shifts, 12-hour shifts, I can't give a lot of in-depth on that. I can tell you our normal process for nursing and nurse scheduling is, meet what the market demands. And in a marketplace, if the demand is there for nurses that want to work 12s, then we'll create scheduling around that. If the marketplace dictates 8-hour shifts, we'll accommodate that. Or if it's a flexible scheduling and they want to do a mixture of 8s and 12s, then we've been able to accommodate that in most regards. And so for the dialysis care, that would be the same thing.
Yeah, that makes sense. Maybe and everybody on the phone will say sort of last call at the bar here, because we're coming up on time. So any final questions, please put them in the Q&A. But Mark, I was curious to hear any final remarks you might have about, we've talked about your partnership with your health systems. I think our teams have developed a really strong partnership as well. Maybe talk about what does great look like? What are you sort of demand of us and other device partners. What do you think best practices are there?
Yeah, so I think a great place to start is to learn what goes on in an inpatient rehabilitation facility. And there's a lot of people that don't know what rehab hospitals do, and the types of patients that we care for, and the acuity level of our patients that we care for. So I think for and certainly in the case of Tablo or any other good partner that we hook up throughout our supply chain, one of the first things they do is to learn our patient needs, what we do in our hospitals. That enables them to better empathize with what our staffs are trying to solve for and how best to do that. So that'd be one. And get our staff, get to know our staff a little bit, those individuals that are trying to make this happen. And once again, I think the team from Tablo has done a really good job in terms of working with our staff in our Vegas marketplace. I think they certainly know the teams that are involved with Encompass Health nationally that are working on this project. And it does become a people relationship, and the more you can know the people involved, the better you can start to communicate and problem solve. And I think our two organizations, Leslie, have done a really nice job in doing that. I think our teams know your team, and vice versa, and collectively we've been able to put our energies towards solving and really doing a pretty darn good job at rolling out now into 62 hospitals.
Yeah, that's great. Well, what's next? We know what's next for the insourcing program. You talked about 90 by the end of this year and another 30 plus for 2024. Any parting thoughts on sort of what's next, future forward for Encompass at a more strategic level?
Well, I mentioned our growth targets earlier, so we're pretty much. It's not like there's a whole lot of idle time putting 6 to 10 hospitals or de novos or 80 to 120 beds or 6 to 8% discharge growth. But we're excited about what we've got going on. We're excited about the ability to expand our services to include dialysis. And it's just another opportunity for us to enable patients that need our care to have access to the services that they need.
That's great. Well, we have been thrilled to partner with you, and most important to us is providing or enabling a patient-centered care model for the first time, which we're really proud to do. And I could not be more thrilled with the outcome here. Our goal is to continue to help you grow in all of those ways. So thank you again for the opportunity.
Thank you. It's been a pleasure.
Thank you. I agree. And thank you for today and sharing your perspectives. So I think with that, we will kick it back to our Zoom moderator, Gerardo.
Thank you so much, Leslie and Mark, for a wonderful discussion and for you all taking the time to join us today. We'll be following up with a recording. Keep an eye out and have a wonderful rest of your day. Thank you.